Today we are going to be talking about attention deficit hyperactivity disorder and attention deficit disorder by Vanessa&Allison. So first we're going to address what is attention deficit hyperactivity disorder. ADHD is a neurodevelopmental disorder which stands for Attention Deficit Hyperactivity Disorder. A child diagnosed with ADHD contains differences in brain development and brain activity. These differences affect attention, the ability to sit still, and self-control. ADHD can impact a child's experiences at home, school, and social settings. Now we are going to define ADD. So ADD is attention deficit disorder. However, it is also known as ADHD predominantly inattentive type. So for the remainder of this presentation, we will refer to ADD as ADHD predominantly inattentive type or ADHD-I. ADHD-I is also a neurodevelopmental disorder and a subtype of ADHD. ADHD inattentive type also affects a child's ability to stay focused. So ADHD is kind of an umbrella term for three different types of ADHDs. So you have ADHD hyperactive, impulsive, which is what we will be covering during this presentation. We have ADHD inattentive type, which will also be covered during this presentation. And then there's also ADHD combined, which we will not cover during this presentation. However, ADHD combined is basically a combination of ADHD hyperactive impulsive and ADHD inattentive. So the symptoms from both of those ADHDs will be present in ADHD combined.
You might be asking yourself, what is the difference between ADHD hyperactive and ADHD inattentive? Children with ADHD-I and ADHD-A present with similar behavioral outcomes. However, there are some minor distinctions between the two disorders. Children with ADHD hyperactive present with hyperactive behaviors. These children are rambunctious and they experience difficulty sitting still and seem restless. Children with ADHD inattentive do not present with hyperactive behaviors. These children seem shy and quiet and are often presenting with behaviors defined as daydreaming. The two names of the variations can be helpful in remembering which symptoms go with which variation. So for example, the behaviors that are associated with ADHD-H mostly fit under the umbrella term hyper. These children are considered to be rambunctious, they may have a difficult time sitting when expected to, and may appear restless. Children with ADHD-I are described as inattentive or daydreaming. They are less rambunctious and they may appear as though they're not listening when they are being spoken to. Symptoms of ADHD-I are less noticeable than behaviors associated with ADHD-H. We will discuss more differences on the following slide. We will now discuss the behaviors associated with ADHD hyperactive and ADHD inattentive. Behaviors associated with ADHD hyperactive include the child seems unable to sit still when it is expected of them. They also appear restless and fidgety and may bounce from one activity to the next quickly. They often try to accomplish multiple tasks at one time, and sometimes they talk nonstop. There aren't breaks, they just have continuous speech. These children also may interrupt conversations or intrude on activities. They may blurt when it is in an inappropriate time, and they may not be aware of the inappropriateness of their behavior. Children with ADHD inattentive may have trouble concentrating. They may become distracted by unrelated thoughts. They may experience difficulty staying focused on tasks. And as I mentioned before, they may appear as if they're not listening. They may seem like they are not paying attention to what you're saying. They may do better on some tasks than others. These children may have difficulty planning, organizing, and finishing tasks on time. and they may also experience difficulty with learning new concepts.
Now we're going to look at some statistics that we found online. So the percent of children estimated to have ADHD has changed over time, and its measurement can vary. The American Psychiatric Association states in the Diagnostic and Statistical Manual of Mental Disorders that 5% of children have ADHD. However, other studies in the U.S. have estimated higher rates in community samples. So we have a chart that we refer to as figure 1.1, and this represents how prevalent ADHD has been in recent years. The numbers displayed in the chart represent millions. So as you can see, from 2003 to 2011, the prevalency of ADHD has increased. However, in 2016, it decreased from 2011 by 0.3 million. Looking further into statistics, an estimated 9.4% of children between the ages of 2 to 17 years of age have been diagnosed with ADHD according to Parent Report in 2016. So between the ages of 2 to 5 years old, approximately 388,000 children have ADHD. Between the ages of 6 to 11 years old, approximately 2.4 million children have ADHD. And between the ages of 12 to 17 years old, approximately 3.3 million children have ADHD. According to data and statistics about ADHD from the CDC, other disorders and behaviors that have been associated with ADHD include behavioral or conduct problems, anxiety, depression, autism spectrum disorder, and Tourette syndrome. These disorders are classified as mental, emotional, or behavioral disorders. As you can see from this chart, behavior or conduct issues are largely associated with ADHD. From previous symptoms discussed in this presentation, we can see why that is. If a child with ADHD hyperactive presents with symptoms such as fidgety, unable to sit still, interrupting, talking too much, this child may seem as though he or she cannot demonstrate proper classroom conduct.
Students with ADHD-H or ADHD-I may exhibit symptoms that will impact or influence their behavior in the educational environment. Children with ADHD-H may experience difficulty remaining seated when expected. So during lesson time or instruction time when they're expected to be seated, they may have difficulty with this. They may exhibit difficulty playing or engaging with peers during recreational time. They may often run about or climb excessively in situations where it is considered inappropriate. They may also talk nonstop or blurt out an answer during inappropriate times, or blurt during conversations when it is considered inappropriate. As the name implies, these students' behavior will be referred to as hyper. So with children who have ADHD-H, their behavior can be described as hyper. On the opposite hand, students with ADHD-I may exhibit behaviors such as having difficulty with paying close attention or making careless mistakes in schoolwork, difficulty sustaining attention during tasks, an example, station work, independent assignments, or group assignments. They may also have difficulty listening when spoken to, so again during instruction time or carpet time when they're expected to listen. They may also have difficulty following directions and completing schoolwork. They may have difficulty with organization of tasks and activities. They may have difficulty participating in tasks that require sustained mental effort, for example, exams that include critical thinking questions. They may also lose things that are necessary for tasks or activities, for example, the instructions sheet or school supplies or specific supplies for an assignment. They may also often be easily distracted, and their behavior presents as forgetful in daily activities. Behaviors can be observed in the classroom by the SLP directly or by the teacher, and then the teacher could let the SLP know what she's experiencing with the child. Approximately 1/3 of clinically referred children with specific learning impairment fit an ADHD profile. Children with specific learning impairment are 2 to 3 times more likely to have ADHD than their typically developing same-aged peers. However, children with ADHD are much less likely to have a specific learning impairment. So an example that we can use to simplify this would be apples are 2 to 3 times more likely to be red, but items that are red are less likely to be apples. Just because it's red doesn't mean it's an apple. Just because the child has ADHD doesn't mean that they will have a specific learning impairment. ADHD has been one of the most frequently reported co-occurring neurodevelopmental disorders in study samples of children with language impairments. For reading disability and ADHD, estimates of comorbidity have varied widely. However, approximately 36% of children with ADHD-I also have reading problems. These reading problems are related to either an ability achievement discrepancy or scoring below the 25th percentile. It was also noted that while girls with reading disability had more inattention behaviors, boys with reading disability had more hyperactive impulsive behaviors. Children with a confirmed diagnosis of ADHD have reportedly poorer pragmatic language skills than typically developing children. However, they are not dissimilar to children with autism spectrum disorder, or ASD. The speech-language pathologists may use procedures from multiple levels to provide a comprehensive treatment plan for each individual client. Although some treatment methods are not within the speech-language pathologist's scope of practice, it is important that he or she knows the etiological category assigned to the client due to its role in determining eligibility and the importance in selecting and designing a treatment plan that best fits the needs of that individual student. When planning treatment, it is important to consider the student's neuropsychological resources and their effect on language learning. Each child with ADHD has different needs, therefore intervention methods may vary. For example, the child's pediatrician may prescribe medication for ADHD. Medication may include Ritalin or Adderall, but it's best to talk with the child's doctor to see if the child is a candidate for this method and what form of medication would be a best match for this student. Other modifications or accommodations recommended by an SLP may be carried out in a classroom setting. This could include moving the child to the front of the classroom or providing checklists or planners to keep the child organized. Also, the SLP could address attention and memory by reducing distractions or controlling task demands. For example, the clinician may require the student to complete fewer items before giving a break or reward, and also implementing ways to limit the distractions in the environment, such as noises, pictures, toys, or objects can be helpful as well. One thing that the SLP can do is maybe just simply saying, first we're going to do 5 questions, and then we have a reward, and then even writing that out for the student so that they can track what they've done, and they know how far they have until they can have the reward, whether it's a break, or a turn with a toy, or playing a game. That can be up to the discretion of the clinician or teacher. Treatment of ADHD requires the development of a child-specific treatment plan that describes the methods and goals of treatment outcomes. Additionally, the treatment plan should include means of monitoring over time and specific plans for follow-up. So although designing the plan is extremely important, it is equally important to include in the plan how the treatment and progress will be monitored and how long you're going to monitor that progress. That's very important to include in the plan as well. Collaboration between professionals is a key component to any process. The speech-language pathologist will collaborate with other professionals to discuss the client's strengths, weaknesses, interests, treatment plans, and assessment results. Collaborators all work together to achieve a common goal, the success of the client. Collaboration is vital to the assessment, intervention, and treatment process. Professionals working with children with ADHD for clinical management for ADHD include teachers and physicians. It could also include various other individuals, however, these are the two that we will be focusing on. Collaborating with teachers is very important. Teachers play a vital role in the students' lives. They are responsible for educating students and following a comprehensive curriculum to prepare students for state examinations. They could also include district-wide examinations, not limited to just state examinations. Teachers also teach skills necessary for daily living. So teachers do not only teach a curriculum, but they also implicitly teach the skills that are required for day-to-day living. The student spends the most time with their general education teacher or special education teacher out of all of the professionals that they see during the school day. So this is a great source of information about the student and can give you information about how they are doing, what their daily behaviors and routines are like, what works well for them, what doesn't, and just overall how they're doing within the classroom setting. Another professional that we collaborate with are physicians. And physicians are required to collaborate with parents, children, and school personnel to determine if the child meets the criteria for having ADHD, in addition to any possible coexisting condition. Identifying target treatment and outcomes and ensuring functional improvement over time are also requirements of the physician. Physicians and parents and SLPs collaborate together. They may not meet face-to-face, but this can be done over the phone or through email, or the SLP may be asked to pay a visit for a clinical discussion about what's best for the student. As I mentioned in the previous slide, speech-language pathologists will work with a variety of professionals in the best interest of the child. Teachers and SLPs will collaborate, and an SLP may consult a teacher to modify the classroom or accommodate the child in a classroom environment. The SLP may also support the child's academic experience by performing a push-in therapy session. Therefore, we will need to consult a teacher to figure out the best time to do so. Even if the SLP is using a pull-out method rather than a push-in method, it's still important to collaborate with the teacher to find a time that works best for the teacher and the student to ensure that the child is not missing instruction that cannot be made up at a later time. The SLP may also ask a teacher to fill out an assessment form to write down any observations made in the classroom. This could include the child's behaviors, how they interact in certain group settings, or how they work on individual work, or just overall their behavior throughout the day or the routines that work best for them. Teachers and SLPs also are on the ARD committee for the child. Therefore, decisions made in the best interest of the child's success are made between the teacher, the SLP, and the various other ARD committee members. The annual ARD meeting is a great time to discuss any accommodations that the teacher or SLP sees as beneficial for the student. And these are going to be carried over into the following school year. So this is a great time for them to collaborate and see what really works best for the individual. Collaborating with physicians, an SLP may record their observations on a standardized rating scale to return to the physician. The SLP may also participate in a clinical interview to examine the child's functioning in addition to parental behavior management strategies. Responsible for assessing the speech and language skills of a child with ADHD-H or ADHD-I. However, this will be a very different experience than evaluating a child without ADHD-H or ADHD-I. It is important to keep in mind that typical testing procedures are frequently not suitable for students who are distractible, and therefore it may be appropriate to accommodate the child by dividing the evaluation up by subtests instead of requiring the child to complete the entire assessment in one sitting. Informally assessing a child may consist of observing the child interact with his or her peers and caregivers, also listening to how the child talks with these same individuals, talking with caregivers about the child's speech and language development, talking with the child to see if he or she is experiencing any difficulties. Simply observing the child can provide a valuable amount of information, such as the child's retail skills, social skills, his or her ability to plan, organize, and pay attention to detail. Formally evaluating the child may include a hearing screening. This portion is especially important for children with ADHD-I. The formal evaluation may also include language assessments, such as a play-based assessment like the PLS-5 or the CAP. It may include a formal speech assessment, such as the Goldman-Fristow Test of Articulation 3 or the Arizona 4. If formal assessments are administered, it is important to keep our focus on the main goal, and that is to learn the child's strengths and deficits so that we can help them be as successful as possible. Therefore, administering the assessment in a way that allows the child to present his or her best work is important. Any deviations from the standard assessment should be recorded in the report.